Hello, this is Kay Afchi, and this is the taped lecture for Learning Plan number 7, Nursing Care of Persons with Alterations in the GI System. First, let's take a look at some of the structures and function of the digestive tract. You can take a minute just to kind of identify the anatomy of the GI tract, and if you would like to do so, you can put this tape on pause for a moment while you review. Otherwise, we're going to go right through the different structures. First of all, we have the mouth, and that's where the chewing takes place. It breaks down the food into pieces while the saliva from the parotid salivary glands mixes with the food. And we have the esophagus that receives the food from your mouth and delivers the food to your stomach. The stomach has cells in the lining that secrete strong acid and powerful enzymes to further break down the food. The food then goes to the small intestines. There are 3 parts to the small intestines: the duodenum, the jejunum, and the ileum. And that's where food is broken down using enzymes that are released by the pancreas and bile from the liver. Then peristalsis moves the food through and mixes it with the digestive secretions from the pancreas and the liver. The duodenum is largely responsible for the continuous breaking down process, with the jejunum and the ileum mainly responsible for absorption of nutrients into the bloodstream. We have the pancreas that secretes digestive enzymes into the duodenum, like I say, the first segment of the small intestines. These enzymes from the pancreas break down proteins, fats, and carbohydrates. Then the liver, its main function within the digestive system, is to produce the nutrients absorbed from the small intestines. So bile from the liver is secreted into the small intestine, and this also plays an important part in digesting fat. Then the liver is the body's chemical factory. It takes the raw material absorbed by the intestine and makes all the various chemicals the body needs to function. The liver also detoxifies potentially harmful chemicals. It breaks down and secretes many of the drugs that are in the person's circulation. The gallbladder stores and concentrates bile and then releases it into the duodenum to help absorb and digest fats. Then next we have the colon, which is also known as the large intestines. The large intestine is made up of the cecum, the ascending or right colon, the transverse across colon, the descending left colon, and then the sigmoid colon, which connects to the rectum. The appendix, you may see, is a small tube attached to the cecum. As stool passes through the colon, water is removed. Stool is stored in the sigmoid colon until a mass movement empties it into the rectum once or twice a day. And then the rectum is where the stool is held until evacuation happens. The anus is a pelvic floor muscle and 2 anal sphincters, both the external and the internal sphincter. And that's where the stool passes out. Okay, we look at the effects of aging on the GI system. Many elderly have dentures or partial plates, which can affect how well they chew. It also sometimes affects how well they can taste. It sometimes, if the dentures are ill-fitting, it can cause a sore mouth, or like I say, an inability to chew the way they need to. Also, the muscles used for swallowing may become weaker and less coordinated as the person gets older. It puts them at risk for aspiration. The esophageal sphincter becomes less efficient at the opening and closing, which also increases the risk of aspiration. taste buds start to atrophy as the person gets older, and they have more difficulty distinguishing between salty and sweet. The parietal cells in the stomach decrease their secretion of HCl, an enzyme and intrinsic factor, so that puts them at risk of pernicious anemia because they're not able to absorb B12 as efficiently as they had when they were younger. The small intestine mucosa becomes less absorptive. The large intestine may develop decreased motility, so that puts them at risk then for constipation. We find they have higher incidence of gallstones as they age, and that there's a decreased secretion of lipase from the pancreas that alters fat digestion and also alters the nutritional state of the elderly. Now let's look at the causes of GI disorders. Causes of GI disorders could be infection or inflammation, physical or chemical trauma, and then also structural defects. Obstructions can be caused by post-op adhesions as well as tumors. There may be obstruction of bile or pancreatic ducts that can cause interference of digestive juices. There could be continuous inflammation that may result in bleeding. We see that with people who have severe cases of GERD. We also note that psychological stress has an effect on appetite as well as GI motility. There may be excessive stimulation of the digestive acid that can cause breakdown in the integrity of the mucous membrane lining of the GI tract. This can cause GI and duodenal ulcers. We find that conditions such as Crohn's disease and ulcerative colitis are correlated with a genetic predisposition. And also certain colon cancers may have a genetic predisposition. And then there are also autoimmune diseases that can affect the GI tract. For example, like celiac spur would be an example of that. What kinds of conditions cause accessory organ disorders? Accessory organs would be like pancreas, liver, and gallbladder. There are risk factors associated with gallbladder disease, such as rapid weight loss. Women are more prone to gallbladder disease than men. The risk factors increase with age, obesity, having several children, diabetes, or Crohn's disease. They find that there may be a genetic link to people who have gallbladder disease as well. Liver disorders can be caused by viral infections such as hepatitis, toxins such as drugs and chemicals, and alcohol. They may sustain liver trauma based on perhaps an automobile accident or something such as that. It's also at risk for parasite infection, and also is a site where oftentimes the cancer metastasis will occur because the liver has a tendency to be filtering out things from the blood, and oftentimes will be the site where cancer cells end up, kind of implanting and metastasizing in that area. Pancreatitis associated with alcoholism, obstructive cholelithiasis, so problems with the gallbladder. It's also related to peptic ulcer disease, hyperlipidemia, can be affected by trauma, and also pancreatitis can be a site of cancer. How do we prevent GI disorders? Again, eating a normal, well-balanced diet, maintaining good oral health to prevent, the infections from occurring in the oral area. Consume sufficient bulk to prevent constipation. Eat or drink at least 8 glasses of fluid a day, and then heed the need to defecate promptly. Example of that would be that they had done studies and found that women who have younger school-aged children have a tendency to be more constipated because they're busy getting the kids ready and sending them off to school, that they don't always heed the need to defecate, so they become constipated. Other things we can do to prevent gallbladder disorders would be, maintain a normal body weight, eat a low-fat, low-cholesterol, high-fiber, and high-calcium diet, avoid rapid weight loss diets, consume alcohol in moderation, and maintain an active lifestyle. How do we prevent liver disorders? We encourage people to obtain immunizations against hepatitis A and hepatitis B. We use standard precautions when handling body fluids, particularly blood. This greatly reduces the risk of infections with hepatitis B and C. We refrain from consuming excessive amounts of alcohol and avoid exposure to known toxic or carcinogenic chemicals. Ways to prevent pancreatic disorders. Again, avoid consumption of large quantities of alcohol. Removing the gallbladder that has gallstones can prevent obstruction of the pancreatic duct with stones. Comply with therapy for peptic ulcer disease. And avoid smoking cigarettes, which decreases the risk of pancreatic cancers. Now let's take a look briefly at the diagnostic tests and procedures. X-rays can be done. They're often done to evaluate, the structures of the upper GI and lower GI system. Can also be done to evaluate the swallowing of a patient, swallowing studies. These are usually done with a barium contrast, so it's really important to note that the X-rays be done in the correct order, because if they're not done in the correct order, they'll have an effect on the results of the other tests. So if we had a patient who was going to have an ultrasound of their GI tract somewhere, we would do that first, because the barium would interfere with, if we did a barium enema or an upper GI series where they swallow barium, that would impact the ability to be able to see through to the other structures, because the barium would be in the way. So we would do a ultrasound or sonogram first. Then we would prep the patient for a barium enema, because we want the barium to be in the lower GI tract, because it won't then affect the upper GI series. If we did the barium swallow first, the barium that would accumulate in the upper GI tract is going to then move into the lower GI tract, and it would affect the ability of us being able to do the barium enema. So the correct order of doing the test would be the sonogram first, the barium enema second, and then the upper GI series third. Other tests that can be done, we can do a CT or computed tomography scan. We could do nuclear medicine scans and magnetic resonance imaging, ultrasound studies as well. Many of these tests require the patient to be NPO. Not necessarily all of them, but quite a few require a patient to be NPO so that the GI tract is empty, or else the patient can be on clear liquids. For endoscopy, we can do an upper endoscopy and look at the stomach, the esophagus, the stomach, and the upper part of the small intestines. For that type of test, again, we would have them NPO, and the patient would receive mild anesthetics such as Versed, where they could still be alert but they don't remember the procedure. And we numb the back of their throat so that the physician or the healthcare provider can pass the lighted tube down to the stomach and small intestines and see if there's any areas of bleeding, any tumors, that type of thing. The endoscopy can be diagnostic. It can also be interventional. If the patient is bleeding, they can cauterize or stop the bleeding from occurring, or they could sclerose it with medication if it's like esophageal varices or something like that. So they can also treat conditions with the upper endoscopy. The lower endoscopy, of course, the patient would have to have some sort of laxative, usually Go Lightly or something similar to that, where they would clear the stool out of their bowels so that the tube can be passed up and the healthcare provider can look for areas of bleeding or signs and symptoms of Crohn's or ulcerative colitis, or they can do biopsies, remove polyps and that type of thing. Biopsies can be done to identify if there's cancer in the area. Lab tests we'll talk more about more specifically when we talk about different conditions, but lab tests that we'd look at the CBC to see if there's any signs of bleeding or infection. We can look at liver function tests, AST, ALT types of things. We can look at lipase for our pancreas. So there are a lot of different tests that we can look at depending upon what condition we're trying to evaluate. Testing of gastric secretions, we can look at if there's blood in the secretions. We can see what the acidity is of the gastric secretions. And then for stool and urine studies, we can do cultures, we can do white blood cell tests, we can check for blood and that type of thing. So if we have a patient going down for a diagnostic test, of course we're going to check for a patient's allergies to make sure that they're not allergic to the contrast. For pregnancy, we need to do maybe a pregnancy test prior to any x-rays for the females. Patient teaching, they need to be taught about what preparation needs to be done prior to the testing that's done. And then the diet, including NPO status and that type of thing. So they need to know if they're going to not be able to eat anything or drink anything prior to the test, or if they can have still clear liquids to keep them from becoming dehydrated. If the patient's not prepared adequately, that could actually delay or require the repeat of the test. So it's really important that the patient understand what the prep is. If the patient's in the hospital, then the nurse, of course, is responsible for evaluating the effectiveness of the prep. And if the patient's not prepared entirely, they may need to contact the healthcare provider for additional, like, enemas or things like that. If the patient's NPO before going down for the test, make sure that you provide oral care. An example of that would be a patient who's going to have a tube passed down their esophagus. We like to keep their oral area clean as much as possible to prevent transmitting bacteria down into the esophagus and the stomach if at all possible. As soon as the patient is done with his exam, if he can have food or liquids or something, make sure you obtain the tray as soon as possible. If the patient's no longer NPO, because we want to prevent any problems with dehydration. And of course, we would also be assessing for signs and symptoms of dehydration. So if we have a patient that we think possibly has a GI problem, we of course would get family history on them to see if they're at risk for any genetic disorders. We would look for any diet or dietary intolerances that may give us an indication of what the problem is. Any presence of pain. When they have the pain, where is it located? Does it occur in the morning or in the evening? Does it occur before they eat or after they eat? That type of thing. Problems with blood clotting. Do they have any issues with, bleeding? We would verify their immunization status to see if they've had immunizations to hepatitis A and hepatitis B. And then, of course, we do a comprehensive history of the illnesses and if they have any exposure to toxic agents. Then when we do our physical assessment, of course, first we would inspect. We check their teeth, their gums, their oral mucosa. We look at their skin color and lesions. Is there any ascites? Do they have any visible herniations in their abdomen? We would auscultate for bowel sounds. Again, bowel sounds are considered absent if there's no sounds that are heard after listening in each of the 4 quadrants for 5 minutes. Hypoactive bowel sounds can be noted in the medical record when no sounds are heard after listening in each of the 4 quadrants for 30 seconds. Palpation, we would detect any tenderness or any masses in the abdominal area. If you feel like a palpating, like mass, that could be a sign of an abdominal aneurysm, so we would not have, a pulsating mass may be a sign of an abdominal aneurysm, so we do not palpate in that area. And then percussion can be done to detect excessive air in the intestinal tract. Okay, for anorexia, mouth care is important before meals to try and get rid of any bad tastes in the mouth. We would provide small meals a day plus small high-calorie snacks between meals to try and boost their nutritional status. We would make sure to document the percentage of each meal and then keep the room odor-free. So if there's anything in the garbage or anything like that, we would certainly make sure that that's taken out before the meal comes. We would weigh our patient every day and record because we're watching to see if they're maintaining or if they're losing weight. We would provide company during meal times and also provide a quiet environment. If the patient's diet is allowing this, having family bring food from home rather than the institutional type diet that they're on may be helpful in stimulating their appetite. And for elderly people, if they stop eating or they're no longer eating and there's no specific cause for this, that can be a sign that they're becoming depressed and maybe giving up hope in their situation. When you're doing nursing assignments to unlicensed assistive personnel, for example, like a CNA, we would encourage the patient to eat slowly and enjoy the meal. We would tell the CNA to feed the patient cheerfully, encourage the social aspect of eating, so stimulating conversation, things like that, and offer small amounts of fluid throughout the day, but limit their caffeine. So of course we would then limit caffeine because it's a diuretic, but definitely make sure to offer them fluid throughout the day to prevent any dehydration. If the patient is experiencing nausea and vomiting, we of course would want to eliminate smells that exacerbate nausea, so be real conscious of that. And also ginger, they have found, is a good natural treatment for nausea, but we do not encourage the use of ginger during lactation or pregnancy because they found that high doses of ginger may raise the risk of miscarriage. So if they use it, they need to use it in moderation. Okay. If patients are suffering from accumulation of flatus, we encourage the patient to exercise, be active, so ambulation is good to help reduce gas and bloating. If the patient agrees, we can put them in a slight Trendelenburg position so their feet and their hips are higher than their head, and that will assist the gas to travel up toward the rectum. We encourage patients to avoid hot or cold liquids, as this can increase flatulence. And we can also give them anti-flatulent medications such as simethicone to alleviate the flatus. For constipation, we identify the cause of the constipation, and causes could be low fiber, low fluid intake, ignoring the gastrocolic reflex, stress, neurological disorders, or opioid medications. So if we identify the cause, we can then help to identify the way to relieve the constipation. Things that we can get from the healthcare provider as far as orders go: rectal suppositories or enemas, orders for stool softener. We can encourage the patient's intake of raw fruits and vegetables if permitted on the diet, and then encouraging them to be up and active as much as possible. If the patient has diarrhea, we can get an order for anti-diarrheal agents such as Lomotil. If the diarrhea is severe, the patient may be put on NPO status till it subsides, and then if they show signs of dehydration, we might need to start fluids intravenously. We can administer probiotics for diarrhea to try and replenish the normal flora of the intestines. And if the diarrhea is caused by infection, stool cultures need to be obtained and antibiotics need to be started. For nursing management of diarrhea, monitor intake and output closely. Make sure to replace lost fluids and monitor the patient for signs and symptoms of electrolyte imbalances, such as low potassium and low sodium, and watch for signs of dehydration. Avoid coffee or tea again, because that'll stimulate, the caffeine will stimulate peristalsis in the intestines. And if the infection is diagnosed, make sure to follow contact precautions and do your best to keep the patient clean and dry for comfort and to prevent skin breakdown. If the patient is suffering from bowel incontinence, this is often related to severe illness, trauma, neurologic damage, or prolonged bed rest. You need to try again to keep the patient clean and dry for comfort, as well as preventing skin breakdown, tracking the time of the incontinent movements, and offering toileting after each meal may help to eliminate the problem. Should incontinence be persistent, the cause should be identified and then a bowel training program instituted. A bowel training program involves the patient should be in a private environment for 20 to 40 minutes after a meal and assume a normal sitting position for defecation if possible, or if not possible, have them lying on their side position if they're bedridden. Then the nurse or patient performs digital stimulation by gently inserting and rotating a gloved, well-lubricated finger into the rectal sphincter. This action should be done on a regular basis to mimic the patient's normal bowel pattern. So it kind of stimulates the sphincter and allows the patient to feel like they need to defecate. A warm drink or prune juice may also help to stimulate the bowels, and consistency and patience are vital to the success of retraining the bowel. We find this done often with patients who have like a paraplegia from a spinal cord injury or something like that. We try to get them on a bowel training program so that they can defecate on a routine basis at the same time during the day, at least every day or every other day. And then in accordance with the National Patient Safety Goals, you need to encourage your patient to call for help during bowel training. So they need to get up and help. They need to call for assistance in getting up. Reassure the patient that calling for help ensures safety and provides an opportunity to observe the progress of the training program.